Yes, we do.
Wonderful. Good evening, and thank you for joining us. I will call the meeting to order. And we do have a quorum. I believe the first item is I need a motion to suspend the rules to have this meeting virtually.
Motion to suspend the rules.
Thank you, Derek, and I need a second.
A second.
Thank you, Cherie and Jessica.
We'll call the roll, starting with Chair Olds-Fry.
Aye.
Okay. Vice Chair Ohanian.
Aye.
Perfect. Cherie Lackey.
Aye.
Amanda Ngola.
Aye.
Thank you. And Kathy Hayes.
Aye.
Great. Thank you.
Wonderful. Thank you. Moving to our next item, we have an approval of the minutes for September 22nd, 2022. Does anybody have any changes to the minutes? Comments? If not, I need a motion to approve the minutes.
I move that we approve the minutes.
Thank you, Amanda, and I need a second.
Second.
Perfect. Thank you, Derek. And with that, Jessica, can you please call the roll?
Great. Thank you, Chair Olds-Fry.
Aye.
Thank you, Vice Chair Ohanian.
Aye.
Thank you. Cherie Lackey.
Aye.
Great. Amanda Ngola.
Aye.
Thank you. And Kathy Hayes.
Aye.
Thank you.
All right. And our next item on the agenda is public comment. Please note, we also have public comment at the end of the meeting, but I'll pause now to see if anybody would like to make initial public comments before we get into our discussion. It appears as though we have nobody indicating that they would like to make a public comment at this point. So we'll move to new business. First, we have a discussion and vote to recommend approval to City Council, mental health service providers for participants referred by holistic case management staff. And with that, I think I'm handing it over to Jessica for discussion.
Yes, thank you. And Marian is here. I've got a lot of support on this meeting. Marian, our housing and grants supervisor, and Sarah, our interim community development director, are here. So Marian, thanks so much for helping me out. Could we, go to the next slide, please. Next slide, please. Perfect, and then next slide. Okay, so as Chair Olds-Fry said, this program is in partnership with our referring agencies. And I just wanted to put this list of participants here who have helped to define the needs of our residents. Just so you don't think that I came up with this alone in my office. I've been in close contact with our City of Evanston victim advocates, our youth and young adult staff, our general assistance and emergency assistance staff. I've also been in touch with a lot of our referring providers, including Connections for the Homeless, Child Care Network of Evanston, Infant Welfare, Family Focus, and the James B. Moran Center. Our referring partners serve different populations with varying needs, and we know that there is an overlap in symptoms or challenges that people and families are experiencing, including grief, depression, anxiety. We know that there's a need for individual and group services, but both must be at discrete locations or locations that people are familiar with and can easily access. And so everything that I've included in the memo and everything that I'm going to talk about tonight, the majority of it came from our community partners who will be referring people. Next slide, please. Okay, so the target populations, we will probably not be able to meet the needs of everyone, but just the populations that we're hoping that this program will serve include parents and young children, youth, our youth population, 10 to 18, families who are newly housed, and adults who are experiencing severe symptoms of depression, anxiety, and working with either city staff or our referring partners. Yep, our parents. So we also want to target households who may be recent immigrants or who may have family members who are undocumented. And we're also looking to support our LGBTQIA+ community. Okay, next slide, please. So this is an estimated number of the services we need. Again, this came from our referring partners. So we do estimate that up to 15 to 20 households could need family counseling, family or individual counseling. And 10 of those might need court reports or DCFS progress reports. We do need a number of support groups. And then we do have a request for additional individual supports. And the individual counseling would be for quite a number of people. Sorry, I couldn't see my screen, but yeah, 40 to 50. I just wanted to point that out. So when we're looking at providers, we're also really looking at capacity in addition to experience working with the populations we're trying to target. Okay, sorry, Marian. Thank you. Next slide. Okay. So we do have money set aside, as committee members know, from prior year support services, and staff is proposing an up to budgets for individual, family or couples therapy, and then for groups. The group budget is a little bit larger, and that is because we do anticipate running a number of groups, but also because I was going to talk to the committee about setting aside a portion of funds for program supports. So we know that people who would be participating in services, especially if they are families with small children, it's anticipated that some groups will take place in the evenings, right around dinner time. And for families with small children or young children, it would be very helpful not only to have childcare, but to also provide food. So this would tack on an additional amount to the individual session for our group sessions. And that is why that up to amount for group sessions, staff is suggesting that it's higher. So I'm also asking the committee to identify a cap for the number of individual, couple, or family sessions, because we do recognize that individuals and people can be in therapy for quite a long time. But the purpose of this program really is to provide immediate relief for symptoms of depression, anxiety, and to provide sort of immediate coping skills. Applications sort of across the board identified that for milder symptoms, 10 to 15 sessions, people could see results from between 10 and 15 individual sessions. And that for more severe cases, people could need 25 or more sessions to really incorporate good coping strategies. So another criteria when we're looking at applicants is a transition plan to help people identify services or find ways to connect with the services that they're in from this program after our sessions kind of come to a close. But I strongly encourage committee members tonight to consider defining that cap of individual sessions. Also, staff was originally going to reimburse applicants quarterly, but I've heard through this process that it would be better to reimburse monthly. I think it would also be better for me in terms of monitoring the budget and keeping our social services committee members informed of the budget. So staff can provide, quarterly if the committee would like, but also monthly, more regular budget and progress reports, just in terms of numbers served and how much money is spent for each category, and the number of groups that are up and running. All right, next slide, please. Okay, so I have to say, all of the applicants were incredibly strong, and all have done amazing work in the community. This is a new process for me, and I've learned so much from the agencies and their applications. I have badgered them all with follow-up questions, and I sincerely appreciate all of the hard work that people have put into these applications. They were quite extensive. I look forward to working with any of the agencies or agency selected. And like I said, a majority of the applicants are already well known in our community for providing services. Applicants demonstrated partnerships with school districts and nonprofit organizations. I can call some out specifically because I enjoyed reading all of the applications and they were all very strong. Monica Garcia with Lakeshore Counseling Services worked with YOU and District 65. We know that Open Studio Project has had partnerships with Robert Crown and other city community centers and Connections for the Homeless, and Impact Behavioral Health Partners has worked with Connections for the Homeless. However, in thinking of the agencies that could provide the services that our participants need and that were most identified by our community partners, staff is really recommending Skylight, Jocelyn, or Metropolitan Family Services, because again, they have the capacity, they could all run groups, and there were there were unique features that each agency offers that I think will make the programs really successful and help participants connect to the providers. So I have to say, agencies that weren't able to offer services in Spanish and weren't able to hold services at unique locations or discrete locations or locations within the community were at a disadvantage. But again, they were all really strong applicants. So I would like, next slide, Marian. Thank you. I would like to open it up to the committee members to talk about the applicants and to ask the applicants questions. All of the applicants are here, and also a lot of our service providers are participating in this meeting. So we've got representatives from North Shore Senior Center, Books and Breakfast, Moran Center, Connections for the Homeless, just to name a few, who can also weigh in and talk about or provide any clarification around the services that their participants would really benefit from. Again, so this isn't just coming from me, it's a whole team effort. And with that, I'll stop talking and let you guys kind of take it away.
Perfect. Thank you so much for that overview, Jessica. Committee members with questions. Do you want to? I can start, but surely we have questions. I I guess I'll just start, but please feel free to raise your hand or just cut me off if you have questions. I like try to give the committee members questions before me. I do completely agree, Jessica, that Spanish is critical to really have that as an offering. Another thing that I think, as we think of the populations that you've listed out that are really critical in experience and capability of serving children, which is a really unique population to serve, and not all organizations have experience or are equipped to serve children. So I think that's also something to sort of keep in mind, along with both the accessibility of the location and the discrete nature of it. So I guess my sort of question to my applicants or just sort of if any of them want to walk through their experience serving the various populations that we are looking to serve with this support, and if they could elaborate beyond, if they would like to elaborate on their experience serving the populations that we are looking to serve. And I don't know if it might be helpful, Jessica, to have that like slide where it had those distinct populations. I know they all probably have it, but. Oh, and Kathy has her hand up too. So in addition to my question about the populations, Kathy, you have questions for the applicants as well.
Yeah. Hi, everyone, and thank you guys so much for doing all this work. I really appreciate the three of the applicants that you suggest, that staff had suggested, already has the capability of the administrative work that's going to be required for this, because some of these families as well as individuals may have issues regarding DCFS, court issues, reporting issues, and so forth. My main concern is after whatever we agreed upon of being sessions, that what happens to how is the patient then transferred out or transferred off onto a long-term therapy milieu, for lack of a better term. That's my question for now.
Well, that's a great question, Kathy. Sort of how do we avoid that cliff? Great.
And I also have a question. So knowing that mental health services are pretty much with long wait lists now, how are they going to handle the influx of new clients, and how would that affect their current wait list if they have one?
Oh, great question, especially because I think some of the people we may be trying to serve might be in urgent need of care. And so what does that look like as they're trying to manage that? Great question. Amanda, I saw your.
I can ask a question. We haven't seen the application, so I apologize if you probably, groups have already talked about this, but if you could maybe talk about some of the strengths of your organization in terms of, how you provide services and to whom you typically, serve. And then it would also be great to hear more about typical session numbers at your organization, like what would be sort of, in your experience, more of like a brief model, and how many sessions do folks usually use for like longer term counseling, those kinds of things?
Great question. Thank you so much. And Derek.
Thank you, Chair. Yeah, I think I echo all the questions that have been asked by my peers tonight. And also I'm thinking about the kind of the cost caps that Jessica, that you had on another screen there, 150,000 for individual. I think it was up to 200,000 for group sessions. How do you, what's the size of the impact for these distinct populations that you think you can achieve based on those caps realistically? So
Great question. Kathy, do you have another question, or that was just from before? Perfect.
That was from before. I just noticed that my hand was still up. I'm sorry.
No worries. I just didn't want to, I wanted to make sure you got your questions in. And I think, I don't know if at this point, I think those are all the questions. And so I don't know how we want to have the applicants answer those questions. And hopefully they recall all of them. And if not, I will do my best to remind them as we sort of work through.
I can invite each applicant to talk to the committee. Hang on, I have my own personal spreadsheet on the side, so I'm probably not going to go in order. I apologize, but let me start with Susan because she has her hand up. Oops. And Susan is from the Jocelyn Center. Susan, can you hear us?
Yes, can you hear me?
Yes.
Oh, but you can't see me. Sorry about that.
It's
It's
all right.
just-
We see your smiling face. It's perfect.
Okay, well, thank you for offering this service to your residents. I'm Susan Resco. I'm the CEO of the Jocelyn Center. We have been providing outpatient mental health services to low-income individuals for 70 years. And I'll just address those questions. We were founded by a child psychiatrist, and so our history is based in children and families. It's about 40% of our overall population base are kids. We have a number of child and adolescent psychiatrists on staff, as well as 4 who donate their time to serve low-income children. So we are very comfortable with very young, 3 to 5 year olds through adolescence and into the transition, really the whole lifespan. So I think the next question was about the long-term effects and if there was a drop off or a cliff. So 80% of our clients are Medicaid recipients. It is the main source of our clientele. So I can imagine that one of the goals for the city is to make it very easy for people to engage, and that means that they don't need to go through a lot of the Medicaid paperwork and assessments, so that your funding will avoid a lot of that. When people are comfortable with their provider and their caregiver, we can then talk to them about enrolling in long-term treatment if that's what they need or want, so that they can continue to receive care well past whatever cutoff point the city has funds to enable. So typically, the average length of treatment for therapy is 18 to 24 months. But again, it's so highly individual that it really just, it depends. And that's why we would offer that once the person is established and comfortable with their provider, we can offer that long-term funding so that they can continue for years if that's what they so wish to do. The wait list, we currently do not have a wait list. So people can engage in treatment, even in the numbers you're talking about. We could get them enrolled immediately into treatment. That is one of the things that we recognize as being not only one of our KPIs, but something that our board looks at on a monthly basis is how fast can we get people into treatment. And so that's should not be a concern for yours. I know that there are lots of wait lists around, but we work really hard to keep those wait lists. Depending on people's schedules, they can come in the same day or within a couple of days, like I said, depending on their schedules. Let's see, the strengths, I think, of the organization are that I think from your perspective, the fact that we can continue to fund this program well after City of Evanston funding is depleted through Medicaid funding. We also provide comprehensive care. So about 20% of our clientele does require medication. And so we have a very robust psychiatric services team that can provide that level of care should somebody need medication. And oftentimes that's either a temporary or a long-term solution. But one of the nice things about providing that comprehensive care is that our team of providers regularly talk to each other. In mental health treatment, if you're seeing a therapist and you are seeing a psychiatrist, you oftentimes need to play case manager for yourself or for your family member, meaning that the doctors and the therapists don't have time to talk to each other. So the patient needs to do that, or the family member. We do that for people. And I think that is really one of the best things that we can do, is provide that coordinated care. And I think the other strength that we would bring to the table is a care coordinator. So oftentimes it's hard to engage people in treatment for stigma, for lots of reasons. So we would allocate somebody to be dedicated to the City of Evanston clients, and would reach out to them to make sure that they're comfortable, that they're engaged, to see if they have any questions, and that they're really sticking to their treatment so that it's effective. If they're not, we look to find out why. Maybe it's not a good match with the therapist. Maybe it's the time of day. Maybe they've got some transportation issues. So we work to uncover what those issues are so that the people can really just focus on getting better.
Susan, thank you so much. If I could just jump in and say, you did an excellent job helping me establish some ground rules, because your answer was concise and checked all the boxes, I hope, for the committee. So I'm going to play timekeeper, and I will also go down the list of providers I see. So providers, if you can raise your hands, but I won't be afraid to call you guys out to see who would like to speak for your agency. Does that sound fair, committee members? Okay. All right. Susan, thank you
And
so
thank
much.
you so much, Susan. Yes, that was a very helpful answer. I was going through my mental checklist of all the things that we asked. So thank you very much.
Yeah, that was great.
All right, next, it looks like we have Jennifer Michael from Metropolitan Family Services. Jennifer, can you hear us?
Yes,
Okay.
yes. Can you see me? Oh, I'm not on screen. I apologize. Is there a way to put myself on screen, or is it just not?
Not that I'm aware of. No, but
Okay, which is probably a good thing, because it's a good thing. So I first want to say that I'm actually the director of public grants. Jennifer Jenks, who's our like mental health guru from Evanston North, is actually was unable to be here tonight because I think she has a client. So I will do the best I can to talk about our programs, but there might be some questions that we might have to do follow up. And I think, Jessica, you've worked with Jennifer Jenks before, as well as myself, that we can make sure we get those answers to you as quickly as possible. I do want to say that I'm going to actually go to the proposals. I don't forget everything. Is that Metro Family Services, I don't know how much you know about us as an agency. We've been around for 165 plus years. we're a multi-service agency who has locations throughout the Cook and DuPage counties. And we provide, and I think, again, one of the strengths of our agency is that we provide multiple service areas. So we don't just provide mental health, but we also provide workforce, domestic violence counseling, as well as early childhood and legal aid services, for example. So we really can provide a wraparound service approach to all of our clients, both internally through our internal services and externally through our partners. With related to mental health services, we have been a certified mental health provider since for about 28 plus years. And our model is our benefit is that we do provide bilingual services and that are culturally and linguistically specific. We have bilingual clinicians who are Spanish speaking. We also provide services not just at one site. We can be flexible and adaptable, so we can do them in the homes. We have telehealth to do them, via telehealth services, and we can do them in the community wherever the client feels the safest and feels the most comfortable in receiving services. Similar to the other the previous presenter, we also have a multidisciplinary team approach to service delivery. So we wrap around a team around our client that includes the clinical clinician, a case manager who can provide that supportive case care coordination, as well as a peer support specialist who actually is a certified peer support person who actually has the direct lived experience to provide additional support for either the families. We serve we serve children, youth, adults, seniors. We have the expertise to serve all those populations. The other thing, I'm trying to think what else in terms of transitional services so that they don't fall off the gap. We also accept Medicaid and Medicare. And so as the previous presenter said, this funding would allow us to engage clients and get them linked into services. And then as they get more comfortable with our services, we can transition, work with them to either sign up for benefits either through Medicaid or Medicare or another third party payer option, either through an insurance, et cetera. So we have all those systems in place to help transition those clients into longer term care as needed. I guess I don't know if there's anything else that I need to address.
Actually, Jennifer, can I ask, I noticed in Metropolitan's application, could you define the number of groups per year and the number of individual clients the agency could take on? I didn't have a good sense of the agency's capacity for Evanston.
Yeah, and that might be a question that Jennifer is going to have to follow up with. I know we provide a diverse group of groups that and then I think we gave you a list or summary list, and I think we would just we would be accountable to what your needs are in terms of capacity. We have our team as a capacity probably can serve like 35 new clients every 6 months. So I think that we could maybe go up to 35 new clients a year. Does that help? I hope.
Yes, thank you.
And
I might
Kathy,
confirm. I'm sorry.
oh no, go right ahead, Jennifer. I apologize.
No, I might confirm that with Jenna. I'll confirm that with Jennifer Jenks as well.
Kathy, you had a question? You have a question?
Yes, Jennifer, thank you so much for coming in and helping out. I truly appreciate this. One of my questions is, you spoke of the agency's capability of being bilingual. Are there, how far does your resources for language, avoiding language barriers go? Do you provide languages in French, Polish, some of our Asian communities and so forth? My next question is, and thank you for providing that information about being able to meet the gap. How long is the waiting list that Metropolitan Services has now in the Evanston area?
So they currently don't have a waiting list in Evanston. As far as per Jennifer Jenks, as far as I know, but again, I can confirm that. In terms of languages, we have expertise in, we have people that can speak Spanish and Polish in the North Evanston community. We also have staff who can speak other languages, like in the diverse Asian, etc. But if we but in terms of accessing those, I would have to confirm with Jennifer what languages that they have that is specifically available in Evanston North. But I do know Polish and Spanish are. And then I'm sorry, what was the next one? Was that
think it's
everything?
a wait list. Yeah, I think you got it right, Kathy.
Yeah, she pretty much got it. But are you all aware that we also have people here that speak French from our Haitian community? And some of the,
Yeah, I was actually not aware. That's really, I mean, I was not aware of that, but that makes sense. We do have access to translation services through our partnership with Heartland Alliance as a language services that we can access translation. And we also have all the Word documentation in multiple languages. But again,
Great.
I would have to confirm with Jennifer what other languages outside of Polish and Spanish that we
Good.
have.
Good,
And I
thank
also
you.
wanted to say we also have a robust DV program because I noticed that was one of the population areas. So we do have DV services and expertise in that area to if that's and also a needed support system.
Yeah, thank you so much for pointing that out, Jennifer. I think especially we're seeing the need for those resources.
Yeah.
And I appreciate you just highlighting that.
Mhm.
Any other questions specific for Jennifer?
All right, well then I'm gonna move her and move on to the next. Everyone's at about 5 minutes, just.
Perfect. And I want
Thank
to
you.
say, as they're moving her, thank you so much, Jennifer. Your answers and your time are very much appreciated.
No, I appreciate this opportunity. Thank you.
All right, next on my list, we have 2 representatives from Impact Behavioral Health, Chris Noper, and I thought I saw Lauren, but Chris, if it's okay with you, I'm going to put you on the spot to represent Impact Behavioral Health.
Sure. Thanks, everybody. So can you refresh me what the questions were?
Yes. The first was experience serving the specific populations that we're looking to serve. I think a understanding of children, bilingual expertise. Second is how do you handle the cliff if people after these services run out? Third, I think we work in wait lists and sort of your general average number of sessions, sort of general approach. Amanda, I'm kind of messing your question up there, but I hope that's in the ballpark. Oh goodness, I think I'm missing one more, but you can start off there and somebody can jump in with the others that I didn't.
Sure. Yeah. Thanks for the opportunity to speak. We're from Impact Behavioral Health Partners. We're Evanston centered community mental health center. Our experience probably focuses mostly on the identified population of those kind of recovering from or recently homeless, newly housed, or those currently experiencing homelessness. We are a permanent supportive housing agency in addition to a community mental health center. And that adults 18 and over, as well as families, are the populations that we serve. We do bill, or we do use Medicaid to fund services. So individuals who came into our programming we would help them connect with that resource, given if they are of low resources or low income, they should qualify and can be connected. And that with that option we would be able to continue providing services indefinitely. We provide long-term therapy as well as case management, and the therapeutic approaches that we utilize are really difficult to identify how many sessions it's going to take to help someone. It's individuals would have access to our employment program. That's a lot more, time. We have a supported employment program, which involves one-on-one work with an employment specialist to find employment that's a good fit for the participant. And that takes, 3 to 4 months for an individual to find employment. With therapy, we do work with short-term goal setting, as well as long-term goal setting, and kind of that process of building towards the recovery people are interested in. In our application, I believe we articulated that, this funding would be utilized to kind of fund initial services until we could get individuals applied to Medicaid, and then Medicaid would then fund the services moving forward. And therefore, this was just meant to be a gap filling funding. While we engage folks, we also have case management and an intake coordinator who would help us to connect with individuals, perform outreach, make sure folks are connected to the resources in the community that we're familiar with here in Evanston, and helping them then participate in therapy in an effective manner, having been connected with the resources that they need. In terms of bilingual services, we do have Spanish speaking capacity in our employment program, but we do not currently have that in the therapeutic or case management program. So I think I touched on the CLIF, and then the average number of sessions. Like I said, in terms of the number of sessions before we could get someone connected to the resources that would help, take care of the cost of their services long term, probably 2 or 3 sessions in terms of getting them connected to Medicaid, and then helping them utilize our services without needing the funding from the city. Waitlist, our intention was to dedicate a full-time staff to this endeavor, so there wouldn't be a wait list. This would be a position dedicated to this task, and that staff would be able to take on roughly 30 participants. I would have to check the application to identify the exact numbers, but depending on the level of need of these individuals, between 30 and 35 individuals that they could be working with, providing therapy. Did I miss anything?
I don't think so, but
Okay.
feel free to raise your hand, committee members, if I didn't get all off. I think that's very helpful, Chris. I really like sort of you highlighting that transition over to Medicaid. I mean, that is a more sustainable long-term, and especially given the populations you're serving, I would be, there are a couple reasons perhaps why there wouldn't be eligibility, but by and large, I would think the population you're serving would fall into eligibility and be eligible. And so that's really helpful. And I think as we think of setting the level of sessions and who we fund, I think it is important for us to think about, for those eligible for other funding, what does that transition period look like? And we want to make sure that these resources are being used for those that don't have other resources to cover.
Right.
Thank you so much. Anything else before we move on, Jessica, to our next applicant?
All right. Next, I have David from Skylight. So, David, can you hear us?
Yes, can you hear me?
Yes.
Great, thank you. Thank you to the whole committee and to Jessica for focusing on mental health. And it just says a lot about Evanston and your progressive thinking and your awareness that mental health services are so important right now. And especially over the last 2 years, even how much the delivery of mental health services has changed. We're seeing people with so much trauma and loss and grief, anxiety, and there's just so many people who need care right now, and we're committed to removing the barrier to people accessing high levels of care where the clinicians are well-resourced and not burned out themselves, where they're supported. And because the providing therapy has changed so much in these last 2 years for the providers who are going through very similar things as their clients. So, this is a great opportunity for us to be able to be talking with you, because we want to make sure there's dignity in the process of people who are receiving services. So I'm the CEO and founder of Skylight Counseling Center. We started in 2011. We're in Evanston and have been supporting the Evanston community, the Niles Township, Skokie community since 2011. We also have location in the Loop. We are pretty rooted in systemic thinking in terms of if we're seeing an individual, we think about the systems that they're in. Their family systems, their cultural systems, their community systems. I was trained at the Family Institute at Northwestern University as a marriage and family therapist, and that really informs a lot of how I think and we think about what we do when we work with people. It's also hopefully supporting the families that have a long background in running groups, as do we as an organization. I taught group psychotherapy in the graduate school at Northwestern for 10 years. And it's really a very effective modality of treatment where participants can be learning from one another, not just talking to their therapists. We have a leadership team and structure that supports our clinicians. A lot of them are clinicians themselves, but we do have plenty of administrators, so that team allows for support for the clinicians so that they're not experiencing vicarious trauma or burnout excessively. That we really believe if we support the providers, they'll do an even better job of supporting the clients. So we do have a diversity, equity, and inclusion focus, and that our therapists are culturally competent. We want to make sure that that our leadership team is a diverse group. We have a lot of inclusion amongst our leadership team. So we're very cognizant of how power and privilege experience, it impacts the therapy experience for those clients. It can be different for different clients in terms of the background of their therapist. So we're very mindful of how that process affects the therapy experience. When we've run groups, we've done them in a private practice setting, but we have an office in Evanston that can accommodate that. But we've done a lot of groups on site, in schools, in programs. It makes it a lot easier to populate them that way when the members of the group are already there, rather than trying to build a group. So we have a lot of experience with partnering with organizations, schools, community programs, such as in Chicago, we partner with Year Up Chicago and Utmost U as part of our community program. And we've been able to just implement groups for them more easily because the members are there. It's already ready to go, and we can do that on site. So we do have Spanish-speaking therapists, including family therapists who speak Spanish. We work with all ages, children's, families, couples, individuals, a lot of work with adolescents. And whenever we're working with a child or a teen, we think about the system that they're in, and if we can also be including any of the family members that might also help support the work. We do have a lot of DCFS experience, collaborating with attorneys and guardian ad litems, and a team that supports the clinicians for these families, so that the clinician themselves isn't dealing with DCFS on their own. We don't have any waiting list. For ongoing care, we do have a foundation that can provide free therapy for folks more on an ongoing basis, less on a limited number of sessions. So that has been one option for us to provide sliding scale and ongoing care. And we do have a team of clinical interns who see people for whatever they can afford. Those are students mostly from Northwestern University or from Adler University, and some from National Louis, who are well supervised, but they are therapists in training. And that gives us a way for people to access ongoing affordable counseling. With a lot of the programs we've partnered with, and our average, I would say, is about 6 sessions clients, but that's really an average, whereas sometimes people don't fully engage, and we have plenty of people who are doing ongoing therapy for months or years. It really depends on the presenting issue, but we have had success when there's been sort of brief solution-focused therapy to keep the numbers more limited. It prevents us from getting into some deeper work, but it hopefully can still allow the client to experience some support and find tools and strengths and resources. Lastly, I think the strength of our organization is we're a little smaller, where there's about 40 of us. But we're a nimble group. We can move quickly to make decisions happen, and we work well with partnering organizations such to be able to help create unique partnerships and opportunities to reach more people. And we do have a strong structure of support on our leadership team that supports the providers. It's a diverse team, and we have folks with availability, and we if we start to get to capacity, we do have the potential to also onboard more providers that we know that could also join our team should our existing staff get overwhelmed. But right now we do not have a waiting list. I think I got all that.
I think you did. You got everything. I just want to ask one clarifying question. It sounds like you do not accept Medicaid. Is that what I'm understanding?
Right, we do not.
Okay.
We've been doing more of the sliding scale therapy to avoid some of the bureaucracy that comes with it. But for the most part, it's just been fee for service at a sliding scale for those who can't afford it.
And is that for your individual as well as your group?
Yes, individuals, group, couples, families.
And your foundation has been able to absorb how much of that scale?
Right now, we're at 26 clients through our foundation. So we've been focused there more on ensuring that the relationship is what heals. So that we're ensuring that those clients can receive ongoing care with the provider they know, rather than us limiting the number of sessions. That's how we've been structuring the services provided through the foundation.
Thank you. Any other questions for David from committee members? All right. Thank you so much, David.
Yeah, thank you.
Okay. Next, if it's okay, I'm going to call out Teja from Urban Balance. And if I could just say, thank you so much to all of the presenters, because I did not warn them that they would be speaking. I said that they would be addressing questions, and they're all doing an amazing job. Thank you guys. And thanks to the panel for the questions.
Well, thank you. So my name is Teja, and I'm the Director of Communications as well as a therapist at Urban Balance. We were founded in 2004, and our clinicians work with diverse individuals, 5+ in age, providing outpatient individual, couples, family, and group therapy, treating many presenting issues, including depression, anxiety, family of origin issues, life transitions, trauma, grief and loss, LGBTQ+ issues, substance use, and really many more. So we have 100+ clinicians, and they come from diverse backgrounds backgrounds and utilize many therapeutic modalities. We have many therapists who identify as part of the LGBTQ+ community, are from various racial and ethnic backgrounds, and speak other languages, including Spanish and Hebrew. Our locations are spread throughout the city and in the suburbs as well, including in Evanston, and we do offer telehealth. We're insurance friendly, and we offer sliding scale rates, including our low internship sliding scale rates. We do not have a wait list. In fact, we could take 100+ new clients per month. We see clients 7 days per week and offer morning, afternoon, and evening hours. We have a dedicated and highly trained intake department, and our clinicians offer both short-term and long-term therapy, depending on the needs of the clients, what the client is looking for, and what therapeutic modality is being used and what makes the most sense. We don't have a clear average length of treatment because people come in with such diverse presenting issues. So we do have some clients who come in, they're looking for, cognitive behavioral therapy for 6 to 8 sessions, or that's what would benefit them. That's collaboratively what is decided upon. And so it is a shorter length of treatment. And then we do have other clients with more deep-seated trauma that, are with us for years. We don't currently offer groups, but we absolutely can. And we have offered many groups in the past, including on anger management. We had a group specifically focused on men's issues, on depression, anxiety, trauma. We had a gender identity group, a group focused on healing from religious trauma, etc., as well as one that I should mention on chronic pain and chronic illness that was quite popular. And we absolutely are able to offer services in our offices, as I mentioned, via telehealth, and potentially through a partnership with the city, we would be able to offer services in other locations too. We have done other partnerships in the past with like hospitals where we did, a group in a hospital on a weekly basis through a partnership. I hope I answered at least most of the questions. I'm happy to answer any more.
Believe you did. I just want to I'm going to ask you the same question I asked before, just to confirm. You did not mention Medicaid. I assume that means you do not accept Medicaid. Is that correct?
Correct. We do not accept Medicare or Medicaid. And similarly to, I believe what Dave said from Skylight, similarly for us, we offer sliding scale rates, and our interns can slide quite a bit lower, but no Medicare or Medicaid.
Perfect. All right. Thank you.
Thank you.
Any other questions from committee members? And welcome, Councilmember Burns. All right.
Welcome. I was on an environment board meeting talking about bag taxes that may be coming to a store near you. So sorry for my.
Oh.
I'm
sure the environment will appreciate it, and we'll get used to not forgetting our reusable bags.
Exactly.
All right. Jessica, we want to welcome in the next applicant.
Yes, I'm going to need a little bit of help here. If there is a representative from Institute for Therapy Through the Arts, I would invite you to virtually raise your hand. Furthermore, I see a Sarah, and that may be Sarah Lang from Open Studio. If so, please raise your hand so I can promote you also. Oh, great. All right. This is Sarah from Open Studio Project.
Oh, hi, everybody. It's nice to meet you all virtually. So I'm Sarah Lang. I'm the executive director, but I'm also a visual arts therapist by training. And I don't necessarily want to compete with Evanston counseling providers, because I believe that all of the people that are applying here do incredibly important work. But I would like to sort of emphasize our community engagement capacity, particularly in the Evanston community. We have grown exponentially in the last 3 years throughout COVID. And I will say that one of the reasons for that is being a grassroots nonprofit that has had a long history working directly with Evanston partners. We opened a space in the Robert Crown Community Center. We have a fabulous new studio in the 5th Ward at the Family Focus Building, where we're partnering with 5 community agencies. We were brought in by Evanston High School to help our teenagers acclimate back to the pandemic. And we now partner with their health department to provide art therapy services and groups after school there. We were one of the only providers to partner with Connections for the Homeless during the pandemic, because we had the ability to go into their drop-in center and directly into their shelter. And we continue to provide after-school programming for YOU and some of our greatest needed agencies. We are actually, in response to all of the work that we have been developing throughout the pandemic, we are about to launch a more extensive art therapy clinical service, because as we've grown, we've been able to hire more clinical art therapists, those that are licensed professional counselors and social workers who've joined our staff in recent years. So we are in a great position to provide more individual and group art therapy services right now, particularly in Evanston. And I can't speak enough to the power of art as a community engagement tool for children and for families. It is a fun, non-intimidating way to get people a trauma-informed and emotional responsive experience. All of our teaching artists and art therapists are trained and are trauma trained, equity bias trained, and we have since developed a very extensive social emotional learning curriculum that I'm actually up in Minnesota right now speaking about this work at the national conference. So it's considered very progressive, and I want to speak to the fact that we are able to really move in, being small and being able, having all of the partnerships that we do in Evanston. We can directly serve clients at our studio at Sherman and Maine, at our studio at Robert Crown, and at our studio in the 5th Ward. So we're super Evanston based. And really also are in 4 neighboring school districts, including Evanston. So we are able to really reach, I think, some of our most needed clients. We have bilingual staff, and yeah, we're right there. We're ready to go. So we really see this as an opportunity to leverage our existing relationships, but also kind of launch a more extensive mental health component to our agency. So I hope that helped to answer questions. We do not take Medicare or Medicaid, but our partner agencies do. So as after school at Family Focus, we are working with that agency. We're working with the Child Care Network, YOU. So all of our partner agencies are referring clients to us that may be served by Medicaid.
Perfect. Thank you, Sarah. And to one question Amanda asked, I think it was Amanda. If it wasn't, I apologize. Sort of the average number of sessions. I know it's hard because obviously everybody brings in a different sort of need, but do you have an approximation, and then sort of how do you handle that cliff after, sort of our coverage would end?
Yeah, so I mean, we actually, in terms of if it's going to be individual sessions, it's a matter of just capacity building that with our existing staff, but we have direct relationships with the area of the School of the Art Institute and Adler School of Professional Psychology. We are constantly training art therapists, so we have an in-house pipeline to expanding our services for both individual and group art therapy. So I feel that we really do have the capacity to bring on people quite quickly who could serve as we in order to sustain this program. We also are getting clinical supervision from an Evanston-based art therapist who's a licensed clinical counselor who has a long history working with fee-paying clients, but she's also overseeing this whole effort, and I think a really valuable resource to the program.
Great, thank you. Any other questions for Sarah? All right. Thank you so much, Sarah. It was really helpful.
Thank you.
Yeah.
Yep, that was
You're on
on,
mute.
sorry. Yep. We have not yet heard from Care Relief, Monica Garcia Counseling Services, Institute for Therapy Through the Arts, Turning Point, or the YWCA. So I'd like to invite, okay, Tina Cortez is here. Hi, Tina, can you hear us?
Yes. Can you hear me?
Yes.
Okay. I'm Tina Cortez. I'm the recently named Chief Clinical Officer at Turning Point in Skokie. We have been in Skokie for 53 years, providing services to individuals, children, families, adults from age 6 all the way through the lifespan. In fiscal year 2022, we provided services to about 1,400 individuals, children and adults, and about 90% of those are low income. We do take Medicaid and Medicare, and so certainly we could get people linked with those benefits, you know, once we get them engaged, and they could continue if necessary. We have no problem doing that and keeping them going as they need to. We have our groups program is particularly robust. I'll start with that in terms of strengths. We run up to 50 groups weekly. Most at this point are during the day between 9 a.m. and 3 p.m., but we certainly have run groups for kids after school, for parents after work hours, things like that, as those things have come up on and off throughout the years. So those are certainly available, and we are ready to add those as needed. We also have a really robust crisis program. We have our living room program, which is a walk-in crisis service for adults in our Skokie location. And we've also just recently received funding to open a living room in Evanston. So that will be happening very soon. We also have a mobile crisis service, and that is available to anybody at any time. It's a 24-hour service. Holidays, everything else, and so that we just started that over the summer, so that, you know, that is not specifically identified by your group as a need, but certainly would be a potential need for any of the populations that you identified, and so we have that in place. We also have Impact Behavioral Services and Peer Services have offices in our building. So we have a direct, while we don't provide the specific either employment services or substance abuse services that those agencies provide, we have a direct pipeline to get clients linked to that if needed. Okay, a number of sessions. As many other providers have mentioned, we don't necessarily have a number of sessions that we prescribe to anybody. Certainly, I think we identified for purposes of the grant approximately 20 sessions for individual. And then our group sessions tend to go on a 12-week cycle. And clients, you know, go to the group and then after 12 weeks determine whether or not they want to continue or move to a different group. So it could be, you know, up to 36 groups a year that clients might attend and just one topic. They could also go to other groups that they want to go to. We have 2 clinicians who currently speak Spanish and work with clients who need Spanish speaking services. We're working to expand on that. In terms of the waiting list, we are also would look to hire for this, so there wouldn't be a wait for the clients referred for this position. See what else I can say about Turning Point. We have many of our clinicians work with clients who are DCFS referred. So we work with DCFS and provide reports as needed around progress and services and things like that and engagement. We have clinicians, we also have case managers in-house who clients can be referred to provide services around Medicaid, Medicare, housing, you know, all of those needs as well. And so we also provide a wraparound approach to services. We have many clients who are there for their individual services. They might be in groups, they might have a family therapist, they might also have a case manager, all of those things happening. And those therapists and case managers are all working together to coordinate services for those clients and for those families. And many of our families come in, and many parts of the family have services, and it all sort of works together. See if I didn't miss anything. I think I hit everything. Was there other questions that I missed?
You touched on something and it made me think, but do you take Medicaid?
We do.
Perfect. I
Medicaid,
thought so.
Medicaid and Medicare, yes.
The way you talked about your mobile crisis and some other things made me.
Oh,
think
so
that-
okay. So the mobile crisis
Oh.
and living room, those services are free.
Okay.
We do and can bill them to Medicaid for people who have them, but we have a grant that covers it. So those services are free for anybody at any time.
Okay, wonderful. Great. Thank you so much, Tina. Kathy.
Hi, thank you so much for your presentation. The services that you're going to be providing with the mobile as well as the living room, will that be the same services that would be covered with this financial request? And secondly, do you also handle patients who are hearing impaired, meaning do you have sign language for the deaf?
So the first question, we have grants from the state of Illinois to provide the living room and mobile crisis. So no, those we would not be asking for coverage for those. We already have that. I was just commenting that those are already in place and would be available to these clients that you would refer to us and anybody else who wants them, that they are, and that we have lots of experience providing crisis services when necessary, but we already have coverage for those. We're not asking for that. We do not have sign language interpreters currently.
Thank you.
Thank you, Kathy. Any other questions? All right. Thank you so much, Tina.
Thank you.
Okay. If we have anyone from Institute for Therapy Through the Arts or the YWCA, please raise your hands. Okay. I don't see anyone, so I think that might be it for our presenters.
All right. Well, I want to just thank all of them. It was incredibly helpful. And we probably put you on the spot there with some questions you weren't prepared for. So sorry about that, but you did a great job. All right. So at this point, Jessica, you are hoping for a vote. Is that correct?
Yes, and we can separate it into 3 votes if you would like, for up to amounts for group and individual counseling, a set number of individual sessions, and then a provider or providers to launch this program.
Perfect. Well, I think we could start with the first, which is probably the easiest. And that is the dollar amount. I believe we've previously discussed these. And so I believe the proposal is $150,000 for group therapy, or sorry, for individual, 200,000 for group therapy.
Yes, and if I could just say, I also asked the committee approve the use of a portion of funds for childcare and food for groups that are offered in the evenings for parents with children.
Okay, so 200,000 for group and necessary support services such as food and childcare.
Beautifully said, yes.
I believe I need a motion to even begin debate, and then we can discuss, and then we can vote. So we have a motion on the proposal, just the dollar amounts.
A motion to have the debate regarding 150,000 for individual and the 200,000 for group and supportive services.
Perfect. Thank you so much, Kathy. And do I need a second and then we can discuss, correct?
Yes.
Second.
Thank you, Derek. All right. Does anybody disagree with those dollar amounts? Anybody have any comments, questions?
I just have a question on how they were conceived. I may have missed that, Jessica, earlier on in the presentation. I'm sorry if I did. How did we come up with those thresholds?
So that's a great question. It was a little bit of a moving target, which is why they are up to amounts, and which is why staff would come back regularly, monthly, to report on outcomes and budgets. But going back to your original question, the Social Services Committee has about 380,000, it's a little bit under, set aside for support services. And staff anticipates that those funds will grow as the committee determines award amounts for, or allocation amounts for, case management and safety net. There will be a fiscal year 23 set aside for support services. And then there will be a fiscal year 24 set aside for support services. So we do anticipate that this budget will grow. We don't know how much it will grow because we always, we have to establish our budget based on estimate, because we do have a set portion from our Human Services Fund, and that portion is $736,373. Hopefully that carries over into our new budget. But then our CDBG portion for public services is always 15% of our entitlement grant plus program income. So that's kind of a moving target. And I can go into great detail about this, but I will instead encourage everyone to consider our action plan for 2023, which I can talk about during our staff report. But all this is to say, we're going on estimates. And if the committee continues to allocate funds for case management and safety net services in the way that they have in the past, the committee will end up allocating about 20% of our total pot for support services.
So Derek, I think Jessica took a little less than the amount we had left over for support services and did her best to split it based off group and individual based off the costs and proposals that she reviewed and saw. And the fact that group often needs support service, so that's sort of basically we have $350,000 to spend and a little extra change, and we're leaving a little extra just in case something goes awry.
Got it. Okay.
And Amanda, Cherie.
I don't have any. That was helpful hearing what you had to say, Jessica. Thank you.
Thanks.
No additional questions.
Right, Councilmember Burns. All right, then
no questions about this. I'll have something to say in the next
absolutely
conversation. Yep.
So with that, then Jessica, I believe we can call the roll. And just to remind everybody, the motion on the table is to allocate up to $150,000 for individual counseling and $200,000 for group counseling and support and necessary support services such as childcare or food.
Correct. Thank you. All right, Chair Letts-Bry.
Yes.
Thank you. Vice Chair Ohanian.
Aye.
Thank you. Kathy Hayes.
Aye.
Great. Cherie Lackey.
Aye.
Thank you. Amanda Ngola.
Yes.
Thank you. And Councilmember Burns.
Aye.
Thank you. Okay.
All right, the next item on the table, I'll need a motion for, and I don't even know how to set that motion because I think we probably need a decent amount of debate, which is the limit of the coverage. Maybe we could have a motion to establish a coverage limit for the support services funding, and then we can debate it, and then we can up the motion with a specific number. Vice Chair Ohanian, Derek?
Sorry, Chair, I'm not sure I follow on when you say motion for coverage limit, what are we trying to define there?
So I guess we don't have to, but I believe it would be recommended to pick a number of sessions that we're going to cover for individuals. But I think in order to have that debate, I need a motion on the table. I realize we couldn't probably pick a number. I guess we could pick a number and then come back to it, but I need a motion to have the debate and discussion on what's the right number of sessions.
Okay. So can we,
Kathy makes that motion. Is that what I'm hearing, Kathy, just for the debate?
yes, just for the debate, because
the
we have a
debate.
limited amount of money and it's not going to go that far. Go ahead.
Right.
That's my
that-
motion.
Thank you, Kathy. I need a second just for the debate, and then we can talk about what the
Okay.
number is. Thank you, Derek. Thank you, Vice Chair. All right. I think to Kathy's point, in an ideal world, we wouldn't have to set a limit. We would be able to just have it meet the individual's needs. And we would also have a lot more money than I think we currently have for this in an ideal world. I think we also want to make sure that we serve the people who need it, and that we're serving a wide array of those people who need it. And so if we don't have sort of those session limits, I think it could be a challenge to ensure somebody like later in the year has the same access as somebody potentially earlier in the year. I don't know where that number is though. So Kathy, you have your hand up. Do you have an idea?
No, I do. Well, I guess here's my idea. Could we think about this in a 2-layered session? And I could be totally wrong, and I'm okay with that. Those that are in emergency crisis who need sessions versus those who are need extenuating, need milder services, interpretive services that pull them in to get them established. And I don't want to make it sound milder, but those that are not in crisis and under fire that have to have a turnaround report for a court system in less than 3 months. So should we look at the sessions in a twofold positions, mild to moderate and urgent crisis? That's my question to the group.
It's a good question. And I very much understood the way you're framing that. Jessica, you have a hand up.
Thank you. I appreciate the question also, and that is a very smart way of looking at it. And the application asks providers to define sort of a number of mild, what it would take to provide relief of symptoms for people experiencing mild challenges versus those experiencing more severe symptoms. However, then it occurred to me that I might have to somehow track that. And so my request would be that the committee approve an up to number of sessions, for example, like 20 or 25, and we leave it up to the provider or providers to help people transition off if they are experiencing relief from their symptoms, or if they learn coping skills in a shorter number of sessions, or if they need a longer number of sessions. So this is really my way of just begging the committee to not put that.
Jessica is not a clinician.
Right.
That I'm hearing.
Right. Well, or I think the challenge for me would be chasing down the clinicians to see if somebody has
Yeah.
received 10 or 15 sessions versus 25 or 30 because they were deemed severe.
No, very fair. I want to add on there, you know, transitioning to other funding sources where applicable and eligible. Amanda, I hate to put you on the spot, but you are, I think, the only clinician on here right now.
Oh, yeah, I think Sherry is too, but yeah.
Oh, sorry.
I think I think it depends on what the goal is. Like, I think people can learn coping skills in 10 or fewer sessions, like with a brief therapy model. Or are we trying to provide options for people who need longer term care? So my background is in college mental health, and I realize it's a different population. But there's typically session limits of like 10 is pretty standard. And oftentimes students will come for like 3 or 4. So I think there are some similarities in the sense of like, there can be like some engagement things, or people kind of feel like they get relief if they're in a crisis and kind of want to move on. So I think it's kind of like, what's our goal? Do we want people to be able to have the option for longer, deeper care? Or is it more crisis oriented or brief, learning some coping skills? Because I think that would make a difference in how many sessions we would want to fund.
That's a great call out. Thank you. And I apologize, Sheree. I forgot that you are also a clinician. I did not mean to exclude.
No, you're totally fine. So I agree with Amanda, like 10 sessions or less. If we're really saying individuals in crisis, solution focused, short-term work, 10 sessions, and then referring to a long-term funding source would probably be best. And then we're catching more clients, right? 10 sessions is what, about almost 3 months worth of sessions, 2.5 months. If you're going into 25, you're talking about 6 months worth of services per client, which is a little heavy.
Okay.
So yeah, so if we're doing crisis kind of coping skills, I think 10 sessions or less would be ideal.
Great.
And I think with group options, I mean, people can go many more sessions, you know, or maybe someone does a group, maybe we allow someone to do some individual and some group, you know, might be a way to extend care longer. That could be an option too, to be sort of efficient, but and also allow for the most people to be served.
Great. And I apologize, Eric. I'm going to ask this question of Amanda, and then I see your hand up. Amanda, for group, like, so that's 10 for individual. Is there a different normal limit, or how group duration? What does that look like?
Well, I think Jessica had alluded to like that people indicated their groups are like maybe 12 weeks, and then, or someone was talking about that in their little presentation about like 12 weeks, and then they can choose, but people do it different ways. Some things are like unending, some are 8 weeks, 10. So it kind of depends on the agency, I think.
Got it. Okay, perfect. Thank you, Amanda. Sorry, not as experienced on the group side. I apologize, Derek.
No, you're fine. I'm off mute. Okay. Sheree and Amanda, question for both of you. So 10 makes sense, and just it's a nice kind of even number that you can, if you wanted to take an average hourly cost, multiply it by, you can come up with some pretty even numbers that then fit into this $350,000 pot, or, you know, 150 for individual and 200,000 for group. So what number, if you had to assign a dollar amount to each of those sessions over the 2.5 months or 3 months, what would that look like?
I think in Jessica's report, it was people had indicated $100 to $160 for an individual session.
And their proposals, I mean, each group had like their own, each applicant had their sort of their regular rate, if you will.
Did Jessica have her hand up, I believe? I'm sorry.
I'm so sorry. Yes, she did. Jessica, go right ahead.
So I can say the majority of the applicants in terms of the number of groups were pretty similar. So like 8 to 12 group sessions. And then, yeah, Amanda, thank you for calling that out. The individual sessions, there was a range, but for the most part, they were from 100 to 160 or 180 on the higher end.
Great. Do we have a motion for 10? Up to 10 individual?
I'm very willing to do a motion for up to 10 individual sessions.
Wonderful. Thank you, Kathy. Need a second?
I second.
Thank you. And Jessica, can you call the roll?
Yes, thank you. Chair Old Fry.
Yes.
Great. Vice Chair O'Hunnigan.
Aye.
Thank you. Shuri Lackey.
Aye.
Thank you. Amanda Ngola.
Aye.
Thank you. Kathy Hayes.
Aye.
Great. And Councilmember Burns.
Aye.
Thank you. Perfect.
All right. Now we have to select the awardees. I'll need a motion. I think we'll have a lot of questions, but I just maybe we can do something again very similar, where we don't necessarily name the awardees in the initial motion and then we amend the motion. So I'll just need a motion to award organizations these support service dollars, and then we'll have the debate. I'll need a motion in a second. We'll have the debate, and then we'll go back and amend the motion with the names of the organization. So I just need a motion to have the debate.
I just do have one concern. There were two that were not able to present. Should we be doing this? Is it all or nothing or some or nothing? I mean, do we want to hear from these other two that didn't present?
Jessica.
So typically, all of the applicants were invited. It was strongly suggested that they have representatives at the meeting. I've made myself available through email and my personal cell phone number in case anyone had challenges logging on. And so I do sort of believe that if there aren't representatives at this meeting, it is an indication that they would like to withdraw their application. I did see earlier someone from the Y hop on. I do believe that Claudette Henderson from Care Relief was on earlier and hopped off. So that would be my recommendation. We've got,
I'm okay with that. I just wanted to know what everybody else thought.
No, I kind of feel, obviously, if there were sort of an emergent circumstance, and somebody had texted Jessica and said, I can't present, I don't know. I think I would be very open to pausing the discussion or at least giving them an opportunity, but without sort of that proactive outreach, I think we've got to go with the presenters that we have. And we have everybody's applicants, our applications that we can, we're basing it off of as well. Do we have a motion just to open the debate?
Motion to open the debate on awarding applicants.
Thank you, Derek. And do I have a second?
Second.
Thank you, Kathy. I think to Jessica's point at the beginning of this meeting, or of the session, very strong applicants. I think, I don't know that there is I don't know that we could go in a wrong direction. Jessica, can you explain to me So if we're awarding 3 groups, let's say 3 organizations, it would be the the case management organization would be the referring, they would refer to one of these 3. Is that correct? Am I understanding that right?
Correct. And this is, again, a new process for me and for the city. So I think my hope would be to keep in close contact with the referring agencies, to understand who they're referring to. And if I could suggest they begin referring to sort of a single agency just to streamline the process. And then if that provider reaches capacity or isn't able to host a group that works for our partners, then we kind of engage the next provider.
Got it. I would you say that your preference, would that just be, I'm gonna pick 2 groups, or I'll just use, I won't even use their names, so just sort of like use, but like say, would it be, all right, this agency is well versed in sort of this population that this care management organization regularly serves perhaps kids. And so your preference would be that they start with the organization that, let's call them organization A, has a strong history of serving children, but maybe this other organization has a strong history of serving the newly housed or homeless population, and they would refer to it would be maybe we pick 3 organizations, they all have 3 different strengths, and the referring agency would sort of start with the one that sort of matches best, but if there were capacity issues, they have those other options. Am I thinking about that right? Or are you thinking everybody start with A and then go to B if A doesn't work?
Well, so that's a great point. I was originally thinking everyone start with A, and then if A doesn't work, go to B. But there are agencies with various strengths, and if we are keeping sort of our different populations in mind, if the committee, what am I trying to say? Keeping our different populations in line, it does make sense to identify providers and then steer participants of select populations to the providers who can best, not best serve them, but yes,
Has the most experience serving that.
yes.
population.
Thank you.
Okay. I do think from that thought process, and just the likelihood that the potential that there could be waitlists, the potential that there could be a very specialized, either language need or service need, that I do think we should do more than one for sure. Just so that there are options. Yeah.
I'm sorry, if I could also say, especially for our youth population, I've had many conversations with Jeremy McCrae, who's our youth and young adult manager, and some conversations with Jerron Dorsey and Audrey Thompson. The youth population really needs a specialized form of engagement. And in fact, all of our groups need a specialized form of engagement. So providers who advertise themselves as, let's say, specializing in like DV services and running DV groups will potentially scare off participants. But providers who, like at one point, Jeremy requested or suggested that a clinician who, or a practitioner who is skilled at working with youth, just sort of come and spend a couple of hours each week engaging the youth and building relationships before even thinking about forming groups or offering individual services. That is the type of engagement youth need. I've additionally heard from like Infant Welfare Society and Family Focus that, again, if the provider comes into the space and advertises targeting, again, people who may be abusers or that would be incredibly challenging. But if we were talking about holding parenting classes specifically for men, having a men's group and then a mom's group, that then the issues come out. And so we hope that the practitioner running those sessions would be, of course, skilled in working with DV and all of sort of the marriage and family issues that go along with that. Again, I apologize, I'm not a provider, so my language might be crude. So to have that, I think it's really critical that providers have that bandwidth to meet people in groups in the spaces where they feel comfortable and to take that very soft relationship building approach. Thank you for letting me.
Yes, oh, thank you. All right, I
Can I just, do we
Yes,
know?
Amanda.
So I apologize. Did you send out the applications and I just didn't see them? I apologize if I am like ill prepared because I didn't see that. I must have missed it. Did you send it out? I'm sorry.
I did send them out and they were included in the packet, but I realized, again, hindsight is 2020. I should have followed up and polled committee members and gotten questions from you guys before the meeting that I could have then sort of moderated.
Well, I didn't see it in the packet. So maybe it was a different email. I apologize because I'm the one that's ill-informed. But I was going to ask, like, do we know if there are agencies that are willing and able to do what you were just describing in terms of lingering with a purpose, with the youth and things? Like,
Yes.
Is that something? Okay.
Yes, there are. Yeah.
and I have, the email was on Friday, October 21st at 11 a.m. If that's helpful.
Okay, yes, I've been out on medical leave, so I was not actively checking my email. So I apologize that I'm the one that isn't well informed here.
No, not at all. Not at all. I just, I feel like you might not be the only one looking for your emails. And so it might be helpful if I gave people sort of a target range. Councilmember Burns.
Yeah, I might have missed the meeting, so I just wanted to understand what went out to all the organizations. Like, what did they respond to? Was it a request for, I don't know what we call it in social services, but like in construction, is RFPs, RFQs? Is that the same type of thing that went out?
So that's a great question. We did open an application in Zoom grants, and when I say we, it was done in partnership. Amanda, I believe that you had the chance to look it over, but correct me if I'm wrong. I also asked Demita Cravens to provide input on the application, as well as other city staff. So it was very much a group effort. And then once I received applications and then had the opportunity to connect with our referring partners like Family Focus and those listed earlier. The emergent needs, those partners identified emergent needs, like the need for court reports for DCFS involved families and more specific services that their populations need. And I can go into a little bit more detail with the committee's permission, because I understand that, we're running late, but that's really where we landed on this idea of youth who need, again, that relationship building. I can also say that our partners identified real strengths in a lot of the applicants. For example, Open Studio Project, and I think Sarah mentioned this, has run art therapy programs for Connections participants that have been incredibly successful. I did hear feedback from our youth and young adult workers that sometimes art therapy for that population can be a little bit hit or miss. So when we talk about diverting some populations to specific providers, that really makes a lot of sense to me. I did not identify Impact Behavioral Health because they don't provide group services, but Impact, again, is a provider who has offered incredible services to people experiencing homelessness or housing insecurity. They work with a very specialized population with a lot of complex needs, including mental illness and substance abuse. And I could go on about
No, that's
all of the agencies who've applied. So sorry, I don't want to take up too much
no,
time.
that's helpful. So this, I think this is the part I missed. So we're 100% of the funding at this point, we want to go towards serving youth and young adult.
No, I would not say
Okay.
that.
Have we come up with a percentage, or how are we looking at how we want to?
So yeah, so I think we've 150,000 for individual, 200 for group. And I think the idea really is that it would be my understanding, I think, is based off of need of where the care manager sort of refer into it. So I think we would just be monitoring it, but I don't know that we would sort of be further narrowing the buckets, so to speak.
Now, is the plan to get to allocate the funds before the service is provided to, or is it just to narrow down the amount of the groups that we're going to work with as needed?
I think it's to narrow down as needed. And then my understanding is that we would be paying after utilization and then monitoring utilization. And so I do think next year or like mid-year, we'll be able to probably have a more new, like, this is so new that I think we're like, we're talking about an idea as opposed to like next year, we'll be able to really understand like how many referrals were there? What was the issue? You know, did we need more referrals for more children, or was it, you know, families, or, you know, what were the needs? I think right now, I don't know that we have ideas, but I don't know that we know what it looks like in the real world application at this point.
Yeah, I think because we haven't narrowed down the scope, which maybe we don't need to, but because we haven't, you know, I would say going with someone that can provide the widest range of services to different demographics is really important. If we were to narrow it down to say, you know, we want to focus on youth and young adult, we want to focus on art therapy, we want to focus on, you know, virtual settings versus in person or whatever it is, then it'd be easier to kind of sort through the organizations based on, you know, what they specialize in. But I think absent that type of criteria, it's really just trying to find somebody that can do it all, hopefully, you know, between one or two different organizations and do it well.
Yeah. I can, go ahead, Jessica. And I agree, Councilmember Burns, with your instincts.
We might have a slide. If we could go back, Marion, would you mind sharing your screen again and going to slide 7? Because that does provide sort of an estimate of the number of group and individual sessions. Thank you so much. So Family Focus estimated that they have about 10 to 15 households who could use family and services for children. Infant Welfare Society also identified 5 to 10 families who would come forward for parent groups, and ideally those groups could be split between fathers and mothers. And then all of our partners identified a big need for individual counseling services, which takes up sort of the bulk. We do anticipate 40 to 50 participants will access individual services. And again, those services, we're looking for an agency who could provide those services at a discrete location that's public transportation accessible, or at a community venue that is already familiar to participants and welcoming, like Family Focus or the library.
And Jessica, do you know if it's mainly adults or, you know, out of the 50 participants you said that would likely need services, do you know if it is more youth or adults that would need those services based on what we've heard from the organization, from the I don't even know how to, we're calling a few different people organizations now, but you know what I mean, from the
Sorry
Yeah.
about that.
No, it's fine.
That's a great question. So I will say, in talking to Jeremy, the Robert Crown sees about 550 youth. He said that, you know, like 5 to 7 families really need more intense services, and about 10 youth really need more intense services. Again, whether they're willing to come forward, that is a challenge. He also requested or suggested groups at Haven, Nichols, or Shoot. Moran Center and Family Focus identified an emergent need to serve really younger children, 5 and younger or 7 and younger. And while there aren't many of those participants, as we've already talked about in this meeting, that is a very specialized provision of services. And then, the bulk we think are going to be families and adults. So it really is something with a lot of components and moving parts, which is why once we identify a provider or providers and launch services early 2023, I hope to stay in close contact with the Social Services Committee to provide lots of updates, not only around the budgets, but around the groups that are running and who's being served.
This is the last question along these lines, but is there a significant need for, you know, therapists or counselors to go into the school and provide the service, or is it an expectation that they would all provide services at their own locations? And I guess I'm really trying to understand the need. You know, are we hearing from our schools and from our outreach workers to say, look, if we could get people in the schools during the day, able to provide services there, that's what they're looking for? Or are they okay setting it up, you know, scheduling time to set up these opportunities outside of school?
They're really looking to set up opportunities outside of school.
Okay.
They're primarily seeing the youth at Crown. And I'm sorry, forgive me for looking at my notes. But here we go. Gibbs Morrison is really the teen spot, Tuesdays, Wednesdays, and Thursdays. And Robert Crown, their prime hours are, again, Mondays through Thursdays, between 5 and 7:30. And so the hope is that a clinician working with youth could establish that relationship, or a practitioner working with youth could establish those relationships. And then if the youth were open to it, perhaps we could set up groups after school at Haven, Nichols, or Shute. Those seem to be the three schools that where we're seeing a lot of mental health need. Yes, thank you. Thank you.
But the services would still be delivered at the school though, after school hours, but physically at the school locations?
The services could be delivered at the school if the students feel comfortable. But really we're thinking primary engagement would happen at Robert Crown because yeah, they are engaged in fun activities and usually they've got food. So
And the only reason I asked that is because I think there might have been a few groups that could not provide. They would need to provide the services on site at their location as opposed to off site. I think I saw that, maybe not. And then I think at least one of the organizations is already at Robert Crown. Did I hear that right?
So Open Studio provides art therapy at Crown. And the three providers that I sort of recommended just to get the conversation going are all able to provide group and individual sessions at community locations. So Crown, including Crown, Family Focus, Infant Welfare Society, the whole nine.
I want to kick it back to the group. I have other questions, but I don't want to take up all the time.
No, these are great questions.
Very, very good questions, Councilmember Burns. I think a lot of, at least Sam, you said it better than I could, but I needed the answers too as well. Other questions from the group? Sarah, were you raising your hand?
It was. I just wanted to say one of our big challenges, of course, is this is so new. And I think we are going to learn a lot as we get going, but we also are going to see shifts all the time just based on. So I think that one of our big challenges is how to get started in a way that we reach enough of the different groups that we can actually learn about how we can work better with them and with our case management agencies as well. I mean, we've got so many different factors. It's not going to be, it's not an easy thing to start, but Jessica's done a ton of work to try to figure out a way. I think it'll be a lot of tracking, as she said, and trying to get back to people. And one of the things I think we'll also find out is the capacity of, what type of volume we have for what needs. And, the thought is that they commit to up to amounts, but they get paid as they actually provide services. And one of the things that we are aware of is if we aren't willing to sort of make enough of a commitment, it's very hard for an agency to work. But at the same time, we might try to figure out some sort of staging or checkpoint to say, well, where is anyone at X point, and see if everything's going smoothly, or if some organization isn't able to make the connections and move on. Could we have some discussions and reconsider and move money around or anything like that? I mean, I don't want to recommend anything that would be completely disruptive to getting started, but there would be the possibility of allocating a certain amount of funding and then having some flexibility to add or subtract from. I mean, probably actually just, you could also leave a sort of part unallocated because it's not all going to be used up in the first 3 months, you know what I mean? And then have some flexibility if you wanted to look at different needs, or if we find out we're really missing something. Just a suggestion that we might be able to consider.
Do we need, I guess I had been operating under the thought process that do we need to select, like, I know we need to select the groups, but do we need to say like up to 20,000 for this group and up to, or okay, great.
We don't have to, but I think that if agencies don't feel that they're going to have enough of a vested interest in working on it, we don't have to. In other words, if we tried to do too many, for example, and everybody, if you averaged it all out, everybody might get a very small amount, then I think we're making it impossible for an organization to make a commitment to really working on this. Not being very articulate.
No. I agree. I just also am glad that we don't have to try to guess on like this amount for, yes. So I agree that you can't pick everyone, but you can have a couple options and we don't have to tailor that amount further. Several questions. Sarah, Jessica.
Sorry, if I could just also add, there are agencies that would appreciate sort of an initial disbursement. Like Skyline could begin to provide services with like a $25,000 initial disbursement. So I think that's very fair. If I could also just say that both Skylight and Metropolitan Family Services have offices in Evanston that are close to public transportation for individuals or families or couples who wanted to receive services, again, at a discrete location that wasn't a community center, but that was public transportation accessible.
Thank you. Thank you for those call outs. Jessica, Kathy.
I'm sorry, I was a little confused for a moment. In trying to establish the guardrails for this particular program, are we trying to select at least 3 agencies that have a specialty that will meet the needs of not only youth, but family? I guess that's my first question. My second question is, then I'll let y'all answer that. Let me stop right there.
I think, yes, we are looking to select a number. I think I might have referenced 3 as an example, but I don't know that 3 is necessarily the right number. I think it might be the number that's sort of in my head, but I don't know that it is the right one. But a small group, a small number of organizations to meet the varying needs of the community and of those specific populations that we've called out.
And now that Jessica, you were saying just now that some organizations would like a upfront payment for services because they have people that are close to the pipeline, or am I misreading that completely?
Staff would just offer that as so that agencies aren't always kind of running in the rears. I think that's, to Sarah's point, something that would show our commitment to getting as many people in services and getting groups up and running as quickly as possible. That would be, yeah.
So is it fair to me to ask that the service agreement would not be enough?
Well, that's, I think one of the things you have to remember is city payments are not always as rapid as private payments. And so one of the things we do in certain cases is we will start out with an amount of money. For example, we did this with the childcare scholarships. You can't always, it's hard to, depending on the size of the organization and everything, cash flow can be an issue and just waiting for payments. So what we've done in cases like that is, as Jessica said, we provide a certain amount of funding based on an estimated number of people in what period of time they think they could probably be taking in. And then they have to report against that. They have to report every case, and we track again, every client they take, and we track against that. And it really can be helpful in getting organizations that have really good ability to meet needs, but aren't necessarily accustomed to sort of
So we would have to do that for, if we go into that practice,
Mhm.
we would have to do that for whichever organizations that we would pick. If we would do it for one, we'd have to do it for the other. Is that correct?
Yes, I think that if they needed
would they
that, there may be
also-
some that say they don't need that arrangement, just as we've run into in some other services. But yes, you know, and this is something that we have done similar things and monitored it against that. And if somebody is not taking in clients and stuff within a certain period of time, you have to have in your agreements that, you know, technically you can get the money back if it's not used, so.
So, but the agencies are going to set their fee for our rate on treatment. So one agency may set their rate at $100, another agency might set it at $50, or a third agency might set it at $160. And we'd still be giving them money up front.
And
Yeah,
those rates
sure.
are in the packet, right? I know there was some. like,
Yes.
Yeah.
Yes, and there's quite a bit of consistency among the different, I mean, you know, there's a range, but there's also, it's not.
Kathy, did you have something else? I'm sorry, I don't want to jump in front of
No,
you.
no, go right ahead. I'm sorry. I
No,
don't
you're
want to
good.
take up all the time.
No, and I appreciate your questions. So I just want to understand scenario 1 and scenario 2 in the packet. So scenario 1, it says approximate cost of a single group held at Family Focus, 10 to 12 participants, meeting for 8 weeks is $8,000. Is that any organization in particular, or is that just a rough estimate of what they all can provide? I'm trying to understand.
Sure, that is a rough estimate, and it's just to show that with the addition of food and childcare support, it would increase the cost of a group session for families with children, as opposed to a group session that maybe doesn't involve families or children. Yeah.
I mean, if that is the dollar amount for 10 to 12 participants, why wouldn't we just work with everybody? I mean, there's only 4 or 5 organizations, right, that presented today.
So we had, hang on, let me count.
Because if I'm doing that math right, we're setting aside 200,000 for groups. You know, that divided by 8,000. I mean, each one, and it doesn't have to be that math, but I'm just saying we've allocated a decent amount to where we really could get a good sense of what they all can bring to the table. Especially if this is a learning period for us where we're trying to get a hang of this to see what works. I don't, with that amount of budget, I'm not sure why we wouldn't want to work with all the groups potentially, especially for groups, because I feel like that's more likely to be a pretty, like each group is probably going to be the same length of time, and you know, it already says here a certain amount of participants. Like I feel like we can manage that maybe a little better than some of the individual sessions, but what am I missing?
Well, so we did have 7 present tonight.
Okay.
And of the 7, there are some providers who do offer a wide range of groups that I think would serve our unique populations, because they do need sort of diverse groups. Not all 7 provide groups. And
That's important, not to cut you off, but that
Mhm.
if we know we want to do groups, it might be good to know which ones don't provide group, because or which ones do.
Yep. So Impact Behavioral Health Partners does not provide groups, and Turning Point provides groups, but not at unique locations. So we're
Okay.
really looking at Urban Balance, Open Studio, Met Family Services, Jocelyn, and Skylight. Of those 5, I think that some of the I think that going with 5 would be a lot for staff. Yeah.
Okay, so it's a staff, and that's fine. And I just wanted to, I was just looking at the math. I mean, even for that, each one could get $40,000. But if it would make reporting, a nightmare, then that's understandable. But
I have another kind of just concern, and I don't know how it will work. Just the timing of we have a number of case management agencies and people who are trying to refer. And if we have too many different places to refer, are we actually going to form effective groups? There are a lot of things we really don't know here, trying to, get things set up, because ideally there could be groups that are from multiple, serving clients from different agencies, different case management agencies. So again, that's not something we really understand yet, but I'm a little bit thinking that if we don't open it up to absolutely everyone and have some limit, it would maybe make management at least initially a little easier, and I think we'll learn pretty quickly what seems to be working.
And that's part of my question. If we, or part of my concern, not my question, but my concern, that if we concentrate on getting the services that we need at a set rate, one, it would lessen the strain on staff on the city side, and it would make clear the measurements of what is or is not available or lacking, since this is so new. If we try to fit the money, I guess if we control the money so that we can then pivot to what needs to be done in the second round, that's something else. But I guess I'm concerned that some of these organizations are already doing this work in different agencies. Are we paying them twice?
Yeah. And that's why I think whether we paid them as needed, or we gave them 40, 20, or 40,000, 25,000, whatever it is, an allocation up front. I would hope this is still based on new clients or new participants seen, and that we could track that it's not based on who they're already, working with or engaging, but that we can verify that it's
yes, and that will be a requirement, and that should be trackable. Both the agencies will have to report it, and it should be trackable to the case management plans as well. So
out of the 5, actually, go ahead, Kathy. I'm sorry, I don't know if you had something else.
No. I was just, if we're doing that for the groups where they're already meeting in groups, then how are we going to address the wide disparity of fees for the individual? I'm kind of lost on how we're doing that.
Jessica, is that something you could answer?
Well, I think my recommendation would be to select an agency for individual services. And again, while all of the agencies are strong, Skylight Counseling, I think would be, or let me say this.
Is that the Evanston-based one that's near public transportation? Is that organization, and that's a different one?
And
Yes,
does youth.
yes.
And does
Do they also
children.
provide group counseling
They do.
on site and off site, or however you want to?
Yes, and
Okay,
as does Metropolitan Family Services. So I'm not trying to, cut anyone out, but I
But
would
they're not
recommend
Evanston
going
based,
with-
right?
Metropolitan Family Services does have an Evanston location at 820 Davis. So that's also public transportation accessible.
Okay.
And if we chose a single provider for individual or family or counseling sessions, that would make the management much easier. Again, until that agency reaches capacity, if that happens, and then we can work with another agency. But I would really love it if all of the referrals from Connections, Family Focus, Infant Welfare Society, Moran were coming through me and then going to a single agency, or all of those partners were referring to a single agency where I could keep track. And I'm sorry, I'm also cutting out city staff, but I don't mean to, because our general assistance, emergency assistance staff, our human resource or our human services specialist would also have the ability to refer, our victim advocates. But again, many referral partners, one site to start out with, or two, but maybe not more than two for individual sessions.
And then have a third in the wing as a alternate if the other two get full. Is that what I'm understanding? Or no?
Sure. Or to Samantha's point, like if the committee feels that Jocelyn has a strong youth services, we know that Jocelyn has strong youth services, we could select others.
For adults.
For anyone, yes. I just want to coordinate. I would just need to coordinate with those agencies that their offices are discreet and public transportation accessible for people who choose to go into the offices. And then for people who don't choose to go into the offices, if they're receiving one-on-one sessions at like Family Focus or Infant Welfare Society, that we're able to stack those appointments. So, you know, the clinician or the provider is there 1 or 2 days a week for 5 hours, as opposed to, you know, 2 hours here, 2 hours there.
Are we ruling out telehealth altogether?
I was just about to ask about telehealth.
You know what? we're not ruling out telehealth, but what we've heard from our referring partners is that telehealth is not the preferred for a lot of participants. There are issues with technology, there are issues with privacy. Sometimes it could be one family member in a room with another family member. Telehealth is not the preferred for participants. And that may change, or there may be participants who are interested in telehealth, but luckily everybody offers telehealth, so we can transition quickly.
Is group and family counseling seen as the same thing, or those are separate?
No, those are separate.
Okay, so where does family counseling usually take place? Where do families typically like that to?
So that's a great question. Families would also prefer to go into an office or have a set location. Families could also meet at Family Focus or Infant Welfare Society, again, for like couples counseling, marriage counseling, or sessions with, you know, families and children. But that would be very different from group counseling sessions for, let's say, mothers interested in parenting skills who might also be wrestling with, you know, violence at home, or fathers looking for parenting skills who might also have anger issues. So those are groups that the mental health practitioners could establish, again, at unique locations, but that are different from family or couples therapy. Did I address your question?
Yeah, and I'm just trying to think, like, out of all the organizations, does anybody stand out as a provider that really excels in the area of group counseling or family counseling? I think there was one standout, at least one for youth and young adults, but does anybody stand out in terms of family? Because to me, everybody can do it, but is there any do we have any evidence that suggests that some of these providers are doing it more effectively than others? So one of my questions, so one of the things that I'm really interested to know is, I wanted to get into this other stuff first, but the next thing I was going to say is really like, also want to know out of all the, I think question 5 in the application really talked about like data collection and outcomes. And that's really important to me from the city perspective, just trying to make sure that no matter what happens in the next 3 months, 6 months, however long this goes, that we have the information, this committee and also the council has information we can use to take action. And so that's one question. Which one do you think answered that question 5 the best, or, more effectively than someone else, another organization? But then also, like, there's some outcomes that they should already have that they presented to us, hopefully in the application. I wasn't able to read them all. But that's another question, like how effective have they been, since they've been operational? And I would imagine there's no feedback from participants, but I'm always interested in that, just surveys and any information from their participants about the effectiveness of the programming. And I also think what's important to me is the diverse counselors, especially to name it, Black counselors specifically, and obviously people who can help address any language barriers as well, but also Black counselors. And so I don't know if there are any questions, that talk about the diversity of their staff.
Yes, so that was a concern of mine, and that is something that we pulled out of applications. And again, Skyline does have a diverse staff. They do have clinicians of color, they have men, and David
That's a big
Coe
one.
is
Yeah.
still here, so I can pull him in. I know that Jocelyn Center also has diverse staff. They have a number of 41% of their practitioners identify as BIPOC, so that would be 86 of their practitioners.
A lot of languages spoken.
Yep.
That's
It
good.
was a very
which
big
one is that?
concern of mine.
That was
Jocelyn.
Jocelyn Center.
Okay.
Right.
Yep.
And they specialize in youth and they accept
And-
Medicaid. So I like that a lot. I am worried
Absolutely.
about that cliff. I'm worried about maybe somebody needs more services, maybe somebody uses their services, they come back. I think accepting Medicaid, especially when dealing with children. I mean, over a third of our children in the state are on Medicaid. So that was very attractive to me.
That's important. Yeah, that's really important.
Yeah.
I mean, those two sound really good. I don't want to, I'll be the first one to kick it off. But I mean, we've heard, was it Skylight or Skyline? I'm sorry.
Skylight.
Skylight has come up a lot about, accessibility, diverse, staff or counselors. I mean, they've come up a few times. They can do on-site, off-site.
Right.
And then also Jocelyn, but these two seem to be really good options. And I don't know if it's, to your point, Jessica, I don't know if you said that you'd like at least one organization to be the go-to for individual counseling, one for group. I don't know if that was what you suggested, but I like these two organizations.
Yeah, I agree. I would also give another strong pitch for Metropolitan Family Services because they do offer a wide range of groups, and they do have a location here in Evanston, and they also accept Medicaid and Medicare, but
and those would be then, I'm going to ask a question that maybe Amanda or Sheree might need to answer, but sometimes there are already established groups or sort of, they meet on Tuesdays at this particular hour and people may come in, they don't all have, there may be a group where it's not all of the members supported by this funding, but like there are other funding sources as well, right? I mean, am I thinking of that?
That
Perfect.
is true. So like Skylight, for example, if people enroll in individual services, they also have the option to participate in any of their group services. David talked about the support from the foundation. Urban Balance is an excellent organization, but I was worried about the cost, and Urban Balance is partnered with the city. Again, fabulous, fabulous. But in terms of that transition plan, there was some challenges.
And that was a concern of mine. If people are going to be charged $160, they're going to quit, in my mind, they're going to quit their therapy if they have no income or no insurance that will cover it, or underinsured that will cover it. That's why I was concerned about the price being dictated to us versus us having a guideline of what the price range, the plum spot would be. Because after they leave the services that we have provided as the city for that, going into that gap, what is the next income source that they would have to continue treatment and services?
And that makes that Medicare, Medicaid, question really important. Because I would imagine every organization has their model that supports the rates, and it might be difficult for them to change those, especially dramatically.
I think our chairs note that if they have groups and people can be individuals from our referrals can be put into an existing group, and we don't have to try to fill one group from all. This is a really good one too, because that means you have a way of getting, in other words, the groups are all based on a sort of individual rate, and that would give people flexibility to get into groups much more easily than trying to make a whole.
I think it could be quite difficult to make a whole group and
Oh,
you're
absolutely.
of everything.
It might be easier with young people than other groups just because, but it would be a real nightmare otherwise.
I'll put something on the table for people to react to. I really like Jocelyn Center for Youth. I hear Jessica on Skylight. I am worried about the Medicaid piece, but I am heartened by both their history of a lower session count and then the foundation. So I do think if they're really averaging that 6 to 8, we might not feel that cliff. And then I really agree on Metropolitan for those groups and that history of diverse groups and that way sort of plugging people in where they might need services. So that's, I don't know. Those are my initial thoughts. I'm very able to be convinced otherwise, but those are my initial thoughts for somebody to react to.
So Skylight doesn't take Medicare, Medicaid, it doesn't take one of them. Okay.
But they do have foundations that kick in.
Yeah.
And they have resources to interns that can continue on. That's why they were a consideration of mine, because they had an ample source of clinicians that could step in at a lower scale or at no scale with the foundation.
Yeah. There is a plan. It's not Medicaid or Medicare, but it is a plan if necessary, it seems.
And did we hear from Trilogy as well?
We did not.
Or Turning Point? Okay, I don't know why I heard one of those.
Did hear from Turning Point.
Was it Turning Point?
Yeah, we heard from Turning Point.
But is Turning Point the one doing the living room?
Yes.
The Turning Point. Okay, I'm getting Trilogy and Turning Point, but they also mentioned I thought they also mentioned the mobile crisis, which I thought was Trilogy.
No.
Trilogy also does mobile.
Also, Turning Point does it in another jurisdiction.
They have different territory technically.
I see. Okay, yeah,
I
I got a
think
little
the territories
confused.
are changing too. So
Because
don't
Trilogy is in our area for the mobile out
Yes.
outreach or service, mobile
Primarily.
service. Primarily,
Yes.
yeah. You know, Evanston and then also parts of Chicago and I think Skokie. Okay, I got mixed up on that. Okay, but their Turning Point is doing the living room. I mean, it may not be. I would like to touch on Turning Point then again because they're going to be seeing people at the living room. Does it make sense to be able to refer then, to a group or to an individual counseling within the same organization? I mean, I just bring that up for continuity in the programming that's provided. But other than that, I like the other groups as well that were mentioned.
If I could say, I didn't promote Turning Point only because they don't offer off-site services. So I was under the impression that they were not able to go to partner sites like Family Focus or.
Okay, that's good to know. And where are they at again? Are they in Skokie?
Yes.
They are currently in Skokie.
Skokie.
Okay, yeah, that makes it difficult. Okay, well then that was why.
Well, and the same is true with Jocelyn. I have to say, Jocelyn can go off-site, but their offices are located in Northfield and Waukegan. So there's a.
Well, that's something to talk about.
Yeah, but they do go off-site and can go to the like
Correct.
The
schools
schools or
like,
the community
or the
centers.
community centers. or whatever.
Yeah.
On a regular basis, are there any limitations? Are they out, mobile and around on a daily basis?
So they specifically requested to stack appointments, which, I'm sure the referring partners and I would do the best we could. And we certainly understand why they would want to stack appointments, but it's a work in progress and we know participants. We're working on that.
It was Jocelyn, it was Skylight, and then what was the third again? Are they local? They're local as well. They have some local sites.
Metropolitan Family
Metropolitan.
Services, the third, yeah, and they are on Davis Street.
Okay. All right. I mean, yeah, I feel good about those three. And then, I mean, obviously we would still, the plan is not to fully allocate all of these funds to these three organizations. It's just to potentially allocate a portion of it and then hold back the rest that we could use to allocate more to these three or potentially look at some of the other groups down the line. Or do we have to stick with this for like a year, or what are we being asked to do tonight?
So I'm asking the committee to recommend to council that we move into service agreements with potentially these three providers.
Okay.
We would offer to provide an initial disbursement to begin services and then pay providers on that fee for service model. So we can gauge how quickly, for example, we're spending for group sessions versus individual sessions, and if there needs to be some readjustment. Yeah.
Well, the intention would be to disperse the 350 to these three organizations and not to revisit other organizations if needed.
So I think that would be the hope. I do think, though, my understanding is that it is like we're reimbursing them on a fee for service basis. So if all of us I'll just pick Jocelyn because they have the application open, but like, let's say our referring agencies can't regularly schedule with them because there are all these complicating things and it's not working out. It is an up to, and if we mid-year think we need another option for our referring agencies, and we still have dollars open and maybe Skylight's capacity is full, like I think at that point we could come back and revisit. Is that right, Jessica? Am I saying?
Yes.
Okay. But it is sort of these are the options for the referring agencies, and like the dollar amounts are based off of the members they serve.
Okay.
And we build this program as a 2-year program. So this is for calendar year 23 and 24. and we can always revisit if we notice, for example, that services for children, there's a real gap and, you know, we don't have providers, we can always revisit, but.
And our revisit, at what point do we review and revisit? Meaning, are we talking 3 months, 6 months, 8 months, 12 months?
Yep.
I think that we would have to, unless nothing's working, I think probably 6 months ought to be our first look. We
Okay.
may not have conclusions. It's a really good question. We just don't know.
But because we're trying to allocate money, we need to run the
Yes.
horse versus run behind the horse.
Yes.
You know what I'm saying?
Absolutely.
So we would need to have some idea of when we want to check in to see
Yes,
where this is going
I
and where
think
we need
that
to adjust.
especially as we get start up, 6 months would be, I think, a good point for us to try to see what's happening and bring it back to the committee so that we can really, it's not that we won't be monitoring things before then. And if we, you know, I mean, like if we had a complete failure, we'd come back sooner.
I agree, but I just wanted to know if we
Oh,
had
yeah,
a
a very good
stationary
question, because it's not
point.
going to be like, oh, we're halfway through the second year and we go back, this wasn't working out so well.
And the
We will
house is
not
on
do that to
fire,
you.
right, and stuff.
My
But
original goal was to provide quarterly reports, but I realized that it's easier for agencies to receive monthly reimbursement. So my offer to the Social Services Committee is to even be able to provide monthly financial and number served reports.
Yeah, I think
Okay.
6 months is too long. I
Well,
was gonna
that's- Yeah,
shoot
you'll
for
get
quarterly.
information, but what I'm saying is
Okay.
draw any conclusions. I think we have to wait a
Oh,
little.
okay, yeah.
Yeah.
Yeah, no, I see what you mean.
Yeah.
But yeah, I think regular updates is important.
We'll see. how
And
quickly-
yeah, like you
Yeah.
said, we don't have to jump to conclusions. But so another thing too is we'll potentially have additional funds to commit to this program at some point within those 2 years, right? So how are we gonna know?
We definitely will. So
Okay.
Social Services Committee has historically allocated 20% of our public services pot to support services, the other two categories for safety net and case management. So we're anticipating, it's always challenging to sort of estimate, but I would feel pretty secure estimating about 150 for 2023 and 2024 to replenish the program.
So 300, an additional 300 total you're saying about?
Yes.
Okay. Yeah, that's good to know.
Because this is money from the unallocated from our 2021, 2022 in essence. So that's why we have this sort of extra at this point. Well, you know, so.
Can I also jump in and say, I apologize, committee, but Tina Cortez wrote that, you know, it might be too late to point this out, but Turning Point can provide groups off-site. They're just not doing it right now. So I don't know if that affects the decision, but it is just full disclosure.
I'll be honest with you, we kind of want it right now. I'm sorry, not to be flippant, but we would need, one of the reasons why I was so interested in some of the other organizations is because they said they had the availability and the flexibility to address these issues now. And if we have students, youth, and families that are deteriorating rapidly according to national reports, I don't think we have the time to wait.
A very fair point. Very true.
Yeah, I think if we had somebody on if we had somebody on standby, I do think Turning Point would be interesting, again, only because we're going to be referring people to them through the living room, and they're going to see, they're a big part of our alternative to the emergency room. And so if they're
Right.
going to be seeing people anyway, why not think about trying them out to provide those longer term services and supporting them, because they're probably going to provide it anyway, but we might be able to get them to provide even more people if we can fund them. So that's the only reason I say Turning Point is an interesting one to consider.
But they can always be brought into the rotation as we
Yeah.
learn to learn how this is progressing as a program, as a service.
Yeah.
And Councilmember Burns, and maybe others know too, is their living room open in Evanston yet? I know they're working, but it's not open yet. Okay.
No.
So
Yeah.
once it opens, that might be something.
Yeah, and that's why I say because I don't know how, I know we said we'll reassess in 6 months, but I don't know. So yeah, we're good, but I'm fine with the 3 though. If somebody wants to, I don't know if we're ready for a motion.
Here, why don't we see if there's any other debate? And if not,
Yeah.
do a motion. Derek? Amanda? All right. I need a motion then, please.
Sorry, can we be clear on restate the organization's name in the motion?
Yes, the motion would be to award this, what are we calling this?
About to develop agreements with
Community service agreements, yes.
service
Ooh,
agreements.
Thank you. To develop community service agreements with Jocelyn Center, Skylight, and Metropolitan Family Services for both individual, family, and group sessions.
So moved.
Thank you, Councilmember Burns. I do need a second.
A second.
Thank you, Amanda. Jessica, can you call the roll?
Chair Olds Fry.
Yes.
Thank you. Vice Chair Ohanian.
Aye.
Thank you. Sheree Lackey.
Hi.
Thank you. Kathy Hayes.
Aye.
Amanda Ngola.
Aye.
Great. And Councilmember Burns.
Aye.
Excellent.
All right, thank you. Sorry, I moved off my agenda accidentally. I was looking at the applications. So let me pull it back up. Am I on? Nope. Okay, great.
Would you like me to introduce? We're not off the hook by a long shot, folks.
I know. We are going to try to go very quickly through these items because we are at 9:45. Next item is a discussion to recommend and approve an allocation of $190,000 to support ongoing food, staff, and safety protocols to prevent and in response to COVID-19.
So moved.
Get right. So moved. Do I have a second?
A
Second.
second.
Great. I have a second from I have 2 of them. And Jessica, can you call the roll.
Okay.
I vote aye.
All right.
And I don't know if we asked if there's any discussion or questions,
Oh, any
which there may
discussion?
not be.
Any discussions? It's CARES funding.
It's straightforward.
Yeah, it's federal money. We like spending that.
Yes, we do. All right, Chair Olds Fry, have you
I
done?
vote aye.
Vice Chair Ohanian.
Aye.
Okay, Sheree Lackey.
Hi.
Okay, Amanda Ngola.
Aye.
Great, Kathy Hayes.
Aye.
Thank you, and Councilmember Burns.
Aye.
Excellent.
All right, next up, I need a motion on the discussion to vote and recommend approval to City Council for an allocation of $60,400 of CARES Act funds for health staff responding to COVID.
I can make a real quick note. Originally, we had set aside 575,000 of ARPA for this, and Ike and his staff, I mean, he's really been good at getting other grants and things like that. We didn't need anywhere near that much. And so that was given back in case anyone was going like, didn't they get a whole bunch of money already? That they released that back to the ARPA pot, so to speak. And this is a great use of CDBG CV because it's directly COVID related, which is required by CDBG much more tightly than ARPA is. So it gives us greater flexibility with our use of funding. And this just assures us these staff people and things that are important to our working of our health department.
Great. Thank you very much, Sarah, for sort of explaining that.
Well, it's very complicated, this back and forth of all these different funding sources.
Yes. Yes, it is.
I'm sorry, Sarah, could you, the cleaning supplies are going to Health and Human Services, right? I mean, the health department, right?
No, the
sorry, what did
cleaning
you just
supplies
say?
are going to Interfaith Action. So Interfaith Action runs a congregate emergency overnight shelter. And the request is to not only clean and disinfect the churches hosting that shelter, but also to clean and disinfect the cots and the bedding and everything that participants need. So the cleaning and sterilization really increase the cost of regular laundry services.
Okay, I'm sorry. I too had obviously bumped my packet off my screen. That's why I was scrambling. Thank you.
Okay, I gotcha.
All right. But I don't have a motion yet, correct?
Correct.
I need a motion. And then we can have more questions too. Thank you, Kathy. I have a motion. I need a second.
Second.
Thank you, Sheree. Any further question or debate on these funds? If not, I can have Jessica call the roll. I'll have Jessica call the roll.
Okay, Chair Olds Fry.
Aye.
Great, Vice Chair Ohanian.
Aye.
Thank you. Sheree Lackey.
Aye.
Great. Kathy Hayes.
Aye.
Okay, you guys switched up on me. Amanda Ngola.
Sorry, it's so late. This is like so past my bedtime.
Sorry.
Sorry, yes.
Oh,
thank you.
I'm right there with you, Amanda. I have tea made for now.
And Councilmember Burns.
Aye. Sorry, I thought my microphone was off. It was not.
Thank you.
Aye.
All right, one more vote in front of us. Committee.
Yes, approval of chair and vice chair, I believe last meeting. We had nominations for myself and for Derek to continue in our current roles. I will speak for I have very much enjoyed serving as chair of this committee. You guys, I learn from you every month. You have just wonderful questions and insights and wonderful commitment to Evanston. And I would be honored to continue to serve in this role as long as you promise not to judge. Sort of after 9:30, I must admit my brain sort of goes off. So I will try to run really efficient committees for you so we end by 9:30. Derek, I don't know if you
Works for me.
Yeah, I echo all of that. I've really enjoyed getting to know each of you on these meetings, and I've learned a lot about the services that we provide to the communities in need in Evanston, and I just love Evanston, and I want to keep contributing to it as much as I can. And so, I'd be happy to continue on in the vice chair capacity. And hope we get to meet in person all someday. I don't know when that'll be, but hopefully soon.
Someday the public health emergency will in fact end.
No, I like this.
All right, I think we need, do we need two
Motion.
separate? Thank you, Kathy. And do we need two separate votes or can we do one?
No, let's do one.
Perfect. Kathy motions.
I second.
Okay.
Thank you, Amanda.
All right, but Chair Olds Fry,
Yes.
great. Vice Chair Ohanian.
Aye.
Thank you. Amanda Nagola.
Yes.
Thank you. Kathy Hayes.
Yep.
Great. Shuri Lackey.
Hi.
Perfect. And Councilmember Burns. Great. Thank you. All right. I'm sorry. I have to keep you guys just for 5 more minutes for my staff report, but I promise I will be quick. The first thing I want to announce is that the draft 2023 action plan will be open for public comment starting tomorrow. That public comment period lasts for 30 days and will close at the December 13th Housing and Community Development Act committee meeting. We are, again, all awards will be on estimate, and this is for CDBG ESG home, and it will have very exciting information about our home ARP project. Okay, my second announcement is about applications. So we do have case management and safety net service applications for 2023 that we will review next month in December 8th. So please set your calendars. I just want to alert the committee that the total request for case management applications.
Sorry, my brain is a little slow. I've been in the meeting too long.
That's fair. I'm sorry.
Kathy.
Okay, case management application, the total request is up. It is 478,000 as opposed to the 310 from last year. Safety net application requests are also increased. It's the total request is $900,620. That is a significant increase over last year when our safety net was at $660,000. And I just need to point out that one request from the Child Care Network of Evanston is to continue the provision of mental health services to children 5 and younger and their families. They were originally providing services through a Northwestern grant that is expiring, and staff struggled with this application because it's sort of like our mental health services that we've just approved tonight, but for a very unique population. But I can also understand, we also understand how it is a safety net service. Because the application deadline for safety net and case management closed at the end of the month, I did not put it on this agenda, and because it's not truly, it doesn't fit our mental health funding model, I chose to put it on the agenda for next month, but I just didn't want the committee to feel like you've heard all of these proposals for mental health, and why is CNE going next month? They did that at staff's recommendation, and we can talk more about it in December before 10 o'clock at night. So thank you, everyone, for everything. I also have, Q3 reports, and the child care premium pay program has expended $450,000 has been dispersed. So we'll end on that positive note, and thanks to everyone for the hard work.
Thank you. That was a very efficient staff report, Jessica. We have public comment opportunities. Anybody want to talk to us at 10 o'clock?
We do have people hanging out, so.
Well, thank you guys for spending all of your hours with us this evening. I believe I have a motion to adjourn. All right.
Thank you, everybody. This committee is one of the hardest working committees in the city, I can assure you. We really appreciate all the thought and work you put into this.
I like to think we're also the most fun. But
Agree with that.
Well,
thank
Thank
you,
you.
everybody. Have a great day. Stay
thank
well.
you, thank you.
Have a great evening.
Thank
everyone.
you.
Good night.
You rock, Jessica.
Oh, you guys, it's all you. Thank you.
No, it's you, girl. Let me get